Now, I have a great honor to invite our next speaker, Dr. Manish Banker. He's the director of Banker IVF Center, Ahmedabad, and he was a past president of Indian Society of Assisted Technology. Welcome you, sir.
Thank you very much. The outset, thank you to the organizers of ISA 2024. The topic that I shall be speaking on, pre-implantation genetic testing aneuploidy PGTA, does it help in improving IVF outcomes? So the next 15 to 20 minutes, I will take you through why is there a need for doing pre-implantation genetic testing? What actually is it? Is it safe? Is it reliable? Is it effective? And I'll end up with our experience and the conclusions of my talk. Now, we all know that out of 100 couples who start with IVF, somewhere around 40 would end up with a live birth. So there is a huge 60% gap from women who start IVF to those who actually go home having a healthy life. And this primarily is because nearly 15% of all recognized pregnancies end up in a recognizable abortion. But if we include all the unrecognizable abortions which happen even before the patient has missed her period, this leads to nearly 50%. So it means 50% of the embryos which implant actually end up in clinically recognizable or unrecognizable abortions. And this is primarily because of an abnormality in the sperm and or the egg and eventually the embryo. We also know that aneuploidy occurs in nearly 20% of all cleavage stage embryos. If the woman is above 35, 36, this increases to 46%, 45%. And if she is 40 and above, nearly 80% of all embryos have aneuploidy. And if they are aneuploid, either they will not implant or they will end up with a miscarriage. In our current IVF scenario, we have two ways of selecting an embryo. One is based on the embryo's morphology, that is how the embryo looks. It is good, but it has observer bias and it does not tell us anything about the ploidy status of the embryo. Or we can supplement this by looking at the chromosomal pattern of the embryo, the so-called pre-implantation genetic testing. There are two types of testings that you can do. PGTA is to look for the presence or absence of the 23 pairs of chromosome. If they are present, it is a euploid embryo. If there are alterations in this 23 pairs, it is an aneuploidy with a monosomy or a trisomy. Or we look for specific monogenic disorders, which is a completely different topic by itself. So this evolved by taking a biopsy from the polar body, because it was thought that why disturb the embryo, and the polar body is extruded after fertilization, so it's a true reflection of the embryo status. This then moved on to removing 1 or 2 blastomeres from a 6 to 8 cell embryo. This had its problem because you are removing a relatively large chunk of cells. From 6 cells, if you remove 2 cells, you are removing 33% of the embryo, and hence the potential loss to the embryo is tremendous. So what we now have is a trophectoderm biopsy. We remove anything between 5 to 10 cells from the trophectoderm surrounding the embryo. So this has a probability of lower damage to the embryo because you are removing fewer percentage of the embryo, plus you have a relatively higher number of cells to analyze and you use advanced technology. So what started in the early 90s with a day 3 biopsy looking at fish or PCR for only 3, 4, 5, 6 sets of chromosome. To 2018 we had the array CGH and subsequently the qPCR and the SNP microarray, where we could look at the entire 23 pairs of chromosome. In the mid 2010s, 2014, 15, we moved on to a blastocyst biopsy, followed by vitrifying the embryo and then doing a deferred embryo transfer of a euploid embryo and the use of next generation sequencing, which provided faster and more accurate analysis of the embryos. So the technique has evolved a lot over the last 25-30 years. If you look at the first systematic review on this from 2011, this was primarily day 3 fish. What this concluded was that there is no evidence of a beneficial effect of PGS as it is currently applied on the live birth rate, because it had a lot of limitations, and it was rightly concluded that it is not as effective in the existing state. 3 years down the line, you have another systematic review. We had now moved to PGS2, that is trophectoderm biopsy and full 23 pair chromosome. But still, the conclusion was that it is unproven and it is an experimental procedure. And unless we have more data, it should not be used in routine practice. It was only in the later part of 2010 that we started getting more and more publications looking at the real evidence, and this is probably one of the first study which looked at next generation sequencing and a blastomere biopsy, and this concluded that it was highly sensitive, highly specific, and it has a potential of reducing the cost of the treatment to the patient, and it is extremely precise. And we now had a systematic review which had 2 RCTs, and this concluded that doing PGTA gives rise to high implantation rate. That means the embryos which are tested with PGT testing and are euploid have a higher probability of implantation, and hence you could reduce or you could carry out more single embryo transfer, and this leads to a dramatic decrease in multiple pregnancies. So we now started having evidence that doing PGT is effective, and it certainly helps in reducing the implantation, reducing the multiple pregnancy rate. So 2015 meta-analysis concluded that this PGS with comprehensive screening was associated with a significantly higher implantation rate and a pooled pregnancy rate of 1.2. When we did a subgroup analysis in patients with recurrent pregnancy loss and in recurrent implantation failure, again we could have a higher live birth rate per embryo transfer, but not high live birth rate per patient treated, because if the embryos are abnormal, you cannot transfer these embryos. Evidence also started coming in from the BEST trial looking at the outcomes of children born through PGTA, and it again concluded that by transferring a single euploid embryo, you are able to have better pregnancy outcomes, because you would have singleton pregnancies and the possibility of healthy children increases significantly. So as the years progress, we started having more and more evidence that doing pre-implantation genetic testing, as this committee opinion of ASRM said, that it leads to higher birth rates and decreases the risks of multiple gestations. But then the question arises that if it is so good, why do we not offer it to all our patients? And to answer this question, we need to know, is it safe, is it reliable, and is it cost effective or not? The first study which started looking at the potential drawbacks of this was this STAR trial, where they did 661 women randomized into PGTA or only morphology, and it concluded that this does not improve the overall pregnancy rate in all the patients. However, if you look at the patients above the age of 35 and those who had more embryos to select from, it did lead to an increase in the ongoing pregnancy rate. This data was reanalyzed by this group from Italy, and their conclusion was that if we transfer only those blastoses which were classified as euploid or normal, it actually leads to a reduction in live birth rate, because you are possibly discarding competent embryos. And this was the first time we started hearing that there is a possibility that embryos which were classified as not suitable for transfer in a PGT testing could actually be transferred, and this was quantified as an embryo loss rate of around 17%. This is not small. So this concluded that the indiscriminate use of PGTA could actually lead to a potential loss of competent embryos, and hence you could have an actual reduction in pregnancy outcomes. And why is this? Let us look at this scenario. When the embryo is euploid, you take a biopsy from the trophectoderm, which is also euploid. So you will have a correct diagnosis of what the embryo is. Or in state B, where the embryo is uniformly aneuploid, you take a biopsy, the biopsy also shows it is aneuploid. So this is correct. A euploid embryo diagnosed as euploid, aneuploid embryo diagnosed as aneuploid. But imagine the other three scenarios. The scenario C, the entire embryo is euploid, only a few cells of the trophectoderm are abnormal. You incidentally take a biopsy from that abnormal area, the embryo is classified as abnormal and you discard it. Actually, it is a normal embryo. Or scenario E, the converse of this, the embryo is abnormal, a part of the trophectoderm is normal, and you take a biopsy from that area and you would classify that the embryo is normal, but it is actually an abnormal embryo. So we know that the concordance rate between the biopsy and the actual status is around 97%, and nearly 1/3 of the embryos show some amount of mosaicism. It means there are more than one cell lines in that particular embryo, and it depends on which cell line has come as a part of your testing. We also know that a single trophectoderm biopsy cannot mathematically tell us whether the embryo is normal. If the embryo has 1,000 cells, looking at 6 cells, it is mathematically impossible that these 6 cells will represent the entire embryo. In addition, it is also believed that embryos have the ability to self-correct. So if the embryo has some abnormality, as it grows, it possibly self-corrects itself. And this was shown from this publication where they did day 3 biopsies in patients, and all the embryos which were abnormal were cultured to blastocysts. These embryos were donated by their patients, and when they did a rebiopsy on the blastocyst, it turned out to be a normal embryo. So it means during the growth, the embryos do self-correct themselves. And hence we know that even mosaic or aneuploid embryos implant. This is a large study looking at healthy babies born after transfer of mosaic or aneuploid blastocyst. We also have a fair bit of experience. 16 patients who chose to have a mosaic or an abnormal embryo transferred because they did not have anything else. We have 3 healthy live births and 2 ongoing pregnancies beyond 12 weeks. So 5 potential pregnancies out of 16 is not bad, but these are all mosaic embryos, not fully aneuploid embryos. So mosaicism is the biggest issue when you are transferring or dealing with PGTA. And this is because, as this study has shown, that they looked at a multi-center study across 8 centers, and what they found that the rate of mosaicism differed a lot depending on the service provider, from 3% to 25%, and hence the outcomes differ based on how accurate the labs are in deciding the PGT status of these embryos. Cost effective, very difficult, but there are very few studies which have shown, because what you need to compare is the cost of PGTA and transfer of a euploid embryo, or if you don't do a PGTA and you transfer all the embryos over 2 or 3 frozen embryo transfers, which is more cost effective. PGTA certainly gives you a pregnancy faster, and it is possibly cost effective also. We now have the new non-invasive PGTA, which is thought to prevent the damage to the embryo by the biopsy. So what we do is take the fluid from the culture media and analyze it for cell-free DNA. So this avoids drilling a hole and taking a biopsy. But the challenge with this is we still need to standardize the procedure. We need to standardize the culture condition. Secondly, if we believe that embryos have the possibility to self-correct, this whole genome amplification study demonstrated that 63% of the blastocysts expelled cell debris which were abnormal. So when the embryo autocorrects, it actually expels all the abnormal cells into the fluid. And if you're analyzing that fluid, you would still have a problem because you would be falsely diagnosing this. So it is believed that this is a product in the market. It has its role, but it cannot take over the role of the invasive PGTA. It possibly only helps in selecting the embryo potential, that if you have 6 embryos, which would you transfer first and which would you transfer second. So a possible way of deselecting embryos but not discarding embryos. So both need to exist together. Another, looking at the pre-implantation testing in patients with recurrent pregnancy failure, large study, 1400 patients, again concluding that PGTA testing has a higher implantation rate and a higher ongoing pregnancy rate. So the position statement from the PGDIS is that patients should be advised that there is a possibility that this technique will not give you a 100% guarantee because of the inherent issues of mosaicism. You must take ample consents after proper counseling, and we should guide them in prioritizing which embryos to transfer first. So what is our experience? We started publishing quite a few years back looking at Indian data on PGTA. We compared it with data in Spain as well. And what we find is that approximately 20% of patients have all of their embryos which are abnormal. In the last 2 years, once we have the ART Act in place, and now we can do it only for medical indications, so it is more of advanced maternal age, nearly 30% of patients above the age of 35 years have all their embryos which are aneuploid. But if you transfer these euploid embryos, you can see that almost all the 200 odd patients which have had transfers have had a single embryo transferred, and you could have an implantation rate of 60%. So these embryos have a very high possibility of implanting. So the question is it for all? One, we have the law which tells us we can do it only when there is a medical indication, and the medical indications that one can look at is recurrent pregnancy loss, recurrent implantation failure, advanced maternal age, severe male factor infertility, along with pre-implantation testing monogenic, because if you're testing for thalassemia minor, you might as well test for any other chromosomal abnormality, and you do PGT structural relocation for patients who have balanced translocation. These are the indications for which I would currently recommend it. So to summarize, where do we stand? Is it for all or in special conditions? Possibly in special conditions, advanced stage, RPL and RIF. But more importantly, what are we looking at by doing PGTA? We are looking at decreased time to pregnancy. We are looking at higher live birth rate per embryo transfer, not per aspiration or per pickup, and we are possibly looking at higher cost effectiveness. But it comes with the risk, possible damage to the embryo by the biopsy, and the entire issue surrounding mosaicism. So to conclude, there is evidence that PGT increases both clinical and sustained implantation rates, but it needs ideal laboratory and technical conditions, and in that it will shorten the time to pregnancy and it lowers the miscarriage rate. You must remember that this testing is governed by the ART Act, and it seems that it is a valuable procedure, but it is not suitable for every patient and definitely not for every IVF practice. Thank you very much.
Thank you, Dr. Manish Bankar, for your excellent presentation. So, to sum up, I would say that PGT is a good thing. It is a good procedure, provided there are valid indications like higher maternal age, RPL, RIF, especially in India, because we have to do cost-effective IVF. If we start doing in every patient, I don't think it is practical. Not to talk of Western countries where it is done for every patient. There it is not allowed to transfer even a single embryo without doing PGT. But in India, I think he has very clearly told us about the real valid indications. Thanks a lot, Dr. Bankar, for your nice presentation. Thank you very much.
Thank you.